Hello friends, I am Jothydev Kesavadev from Kerala in the south of India, and this is a lecture on herpes zoster vaccination. And this is meant only for clinicians, modern medicine doctors, and this is meant only for educational purposes. And let me start sharing the slides. Uh, the title is Preventing Herpes Zoster in People with Diabetes and Cardiometabolic Illnesses. So this is me, Jodhide, and these are my disclosures. And as indicated, this is a session that I have delivered in multiple conferences, and the slides are created primarily by GSK, the makers of Shingrix Vaccination. You may be wondering, me being a diabetologist, then why I should be discussing and lecturing on vaccinations. I'm a strong believer of prevention and evidence-based medicine. And this is one paper that we have published long ago in 2012 when we thought that it is necessary to have a guideline for vaccination in diabetes. So when I was using vaccines against pneumococcal and influenza, there was some criticism. Why it is essential in people with diabetes. And hence, multiple key opinion leaders from across the country gathered, and this was published in Indian Journal of Endocrinology and Metabolism way back in November of 2012. And this is where we discussed about all the necessary vaccines in people with diabetes. And of late in 2024, we have updated, and this is published in International Journal of Diabetes and Technology. And almost similar others as earlier, where we have incorporated the new vaccines, including herpes zoster. And this is RSSDI, our own organization, the largest organization for diabetes in India, perhaps in the world, where we have again incorporated herpes zoster to be included in the vaccination schedule for people with diabetes. And the question is why? Why people with diabetes require vaccination? Why in cardiometabolic illnesses? Of course, we know that there is a rising clinical tsunami in the country, and it is escalating, not only diabetes, not only obesity, but the cardio-renal and other metabolic consequences and the coexistence. It amplifies the overall disease burden. And we call it cardiovascular kidney metabolic syndrome, or CRM, that is cardiovascular disease, CKD, and diabetes. Of course, these are driving a major health crisis in the country. And there are multiple reasons. If you look at the pathogenesis, the vascular remodeling, thrombosis and rupture, and there is impairment in diabetes, both for innate and adaptive immunity, disruption in the protective barriers in the skin, in the lung, in the intestine, varicella zoster entry via insulin degrading enzymes in chronic kidney disease. Again, there is reduced immunity, there is declining renal clearance, multiple reasons for immunosuppression and impaired barriers. So there is an increased risk of herpes. And if you look at the literature, more than 80% of those affected by herpes zoster, it is in age above the age of 50 years. Of course, even a 40-year-old can develop herpes zoster, but there is a steep rise in the incidence of herpes after the age of 50 years. And the commonest dermatome which is affected is the thoracic dermatome, 38 to 70%. And post-herpetic neuralgia is one of the terrible consequences of the disease. Of course, we speak about herpes zoster not only because of the disfiguration, but also because of the pain of neuralgia. And the secondary bacterial infections are also not that uncommon, even in the absence of diabetes. And if somebody is asking you, is it that common an illness? Yes, of course, it is very common. And it is 1 out of every 3 people. They can develop herpes zoster in their lifetime. So it is a very common disease. And once you have a chicken pox, the virus, the varicella virus will be sleeping, will remain dormant in the sensory ganglia, in the dorsal root ganglia. And then later on in life, it will become activated. There is a reactivation. This is a symptomatic reactivation of the same virus, and this is characterized by the typical vesicular lesions, very, very painful, usually affecting only one dermatome at a time. So let me, with this introduction, discuss diabetes, and then we will go to the other complications. So why diabetes? Diabetes is so prevalent in the country, more than 100 million people affected, and there is approximately 38% increase in the risk of shingles in people with diabetes. And once there is shingles, there is uncontrolled glucose. 24% has an increase in the A1C, and there is a 63% increased risk of hospitalization. So that is the risk when it is affecting people with diabetes. And I am thankful to Dr. Sanjay Ghosh of Calcutta. There are a couple of doctors who have presented and they have given the consent to have some slides in this presentation, and also the clinical background. And this is a summary of the case history. And this is a 61-year-old gentleman with uncontrolled diabetes and with controlled hypertension. So he has presented to doctor with a chest pain. So easily we could have made a diagnosis of a heart attack, but when he was exposed, look at the rashes, anterior and posterior side of the chest, a typical grouped vesicles, dermatomal distribution is also very typical to make a clinical diagnosis, an easy diagnosis of a herpes zoster. And late presentation, it was a week after the eruption, and they have applied topical steroids. They have seen somebody nearby, and this has aggravated the lesions, and of course, they were secondary infection. So what happens when there is a herpes zoster? There is depression. And people with herpes zoster, they will have a disturbed sleep, and they cannot mingle in the society. They have to be isolated, and they will develop scars, especially when there is a delayed initiation of the treatment. And he was given valacyclovir, gabapentin, all the typical therapies, and it subsided. But the post-herpetic neuralgia is fairly common in diabetes. It is 45% higher in people with diabetes. So remember, it is not only for prevention of herpes, the vaccine is recommended. It is also for the prevention of the painful, disabling, disappointing, depressing post-herpetic neuralgic pain, which is very common in diabetes. Let me now move on to cardiovascular disease and herpes zoster. There is a 34% risk, which is high in shingles for people with cardiovascular disease. But imagine that somebody is having herpes zoster. Within the first 1 month of a herpes zoster, there is a 35% increase in the odds of developing an MI. And there is a 34% similar increase in the risk of developing a stroke within 3 months of shingles when compared to a control population. So that is the importance of preventing shingles. So the vaccine is not just meant for preventing the infection. It is also meant indirectly for preventing cardiovascular illnesses such as an MI or a stroke. And a similar statistics is also available for influenza vaccine. Many of you probably will recall. And thanks again to Dr. Varun from Coimbatore for sharing this case with us, including the pictures of a gentleman only 50 years old with uncontrolled diabetes, A1C of 10%, with a pre-existing coronary disease. And here again, he has developed lesions over the T6 dermatome. Very easy to make a diagnosis, but he was readmitted on the 10th day. And this is an acute STEMI. So you can see the ECG changes over there. There's STT changes. And he developed an LV dysfunction, volume overload due to the pre-existing kidney disease, pre-renal acute kidney injury. And he had problems shifting to the cath lab as the patient was too sick. So it is highly complicated when there is herpes in a person with diabetes, especially when it is uncontrolled. The LV function improved within 3 weeks. What is the impact of disease? Disfigurement, number one. Prolonged hospitalization. And the stress for the family, financial burden. There is an increase in the pill burden, and ultimately, even this 50-year-old will have a depression because of multiple reasons. So these are the key learnings for the diabetologist, for the physician, for the endocrinologist, and for the cardiologist. You have to control diabetes appropriately, and the vaccine could have prevented herpes as well as all these complications. So So it is a vaccine preventable disease. And if you look at the statistics, MI risk increases by 68% within the first week of the infection. Varicella is also linked to the need for a permanent pacemaker due to complete heart block established. And these are all in the literature. Stroke risk increases by 2.4-fold in the first week after herpes zoster. And this can lead to a serious complication, that is viral myocarditis. And people can even die. And this can happen even weeks after an acute herpes zoster infection. So cardiovascular events and many other complications spike after shingles. And chronic kidney disease and herpes zoster, 29% increased risk of shingles in people with chronic kidney disease. And when somebody with a chronic kidney disease is developing shingles, then there is an increased risk for progression to end-stage kidney disease, and that is 36% increase when compared to those who don't have chronic kidney disease. So it is definitely a risk factor for initiating a dialysis or a transplantation. So this is Dr. Vivek, a consultant nephrologist, and he was also kind enough to give the consent for sharing this clinical case. Thanks to the doctors. A 56-year-old gentleman, and this is CKD stage 3. Long duration of diabetes and hypertension, and already the EGFR is declining, and the patient has presented with a vesicular rash, and initially it was thought that it was a fungal infection by a nearby doctor, and he was applying the antifungal ointment, and this also happens, unfortunate, and the creatinine has worsened, the recovery has been delayed, there was a terrible pain. So this is a suffering. Herpes zoster is a suffering many a time, and CKD is a risk factor, and in early stages of CKD, it can progress to the end-stage kidney disease. Early identification, important, and vaccination, I would say that it is mandatory for those with chronic kidney disease, especially in the presence of diabetes and other comorbidities. You know that the presence of these illnesses, it increases the risk by multiple fold. For example, in organ transplantation, those on immunosuppression, those having malignancies, 3 to 6-fold increase risk in the development of herpes zoster. So herpes zoster develops when there is a physical stress, when there is immunosuppression, when there is malignancy, when there is organ transplantation, and even when there is physical and mental stress. So after a herpes zoster infection, the risk of end-stage kidney disease surges in chronic kidney disease patients with diabetes and a coexisting hypertension. 53% greater risk of progression to end-stage kidney disease, and that is final stages requiring renal replacement therapies. It is worth prevention, and the vaccine is around. Of course, it is a relatively new vaccine, and this is another one in a person with early post-transplant herpes zoster in a renal allograft recipient. Thanks again to Dr. Sahu from Hyderabad for sharing this case with us and giving us the consent to present it before the doctors. A 56-year-old gentleman, and he is a renal allograft recipient, and he has developed multi-dermatomal lesions on the right face and ear 4-week post-transplant. So initially, again, the diagnosis was missed, and this is the classical picture of a herpes zoster with post-herpetic neuralgia due to immunosuppression, and there is worsening of the renal parameters. We can see the EGFR has declined, the transplant recovery has been delayed, there is severe post-herpetic neuralgia lasting for, classically, description is lasting for more than 3 months. And here again, it is asked, look at the emotional status of the person, the family members, depression, emotional distress, increased risk of rejection. So he was started on valociclovir. So look at the key takeaways. It is the same in all these cases. This has been a vaccine preventable case. It remains a mainstay. Vaccination remains a mainstay for preventing herpes zoster and its complications in pre and post-transplant periods. Of course, herpes zoster ophthalmicus is a rare complication occurring only 10 to 15%, involving the ophthalmic division of the trigeminal nerve. But corneal involvement can happen in 65% of herpes zoster ophthalmicus cases can be keratitis, keratopathy, it can even lead to blindness, apart from disfigurement. And this is so depressing for the patient and for the family members. So let me now provide you with the guidelines. And these guidelines are from the scientific bodies from all over the world. And these are the cardiovascular societies, such as the American College of Cardiology, from the diabetes organizations, such as the American Diabetes Association, from the ACIP. We all refer the ACIP for all these vaccines, especially the adult vaccines. And in chronic kidney disease, you have the recommendations of the KDF for the same herpes zoster vaccination. And what about India? In India, we do have the recommendations of the RSSDA from our mother organization, and that is Indian Medical Association, from the Cardiological Society of India, from the Indian Chest, and also from our Association of Physicians India, from the APA also. All these organizations have strongly endorsed the use of adult immunization and recommends the use of recombinant zoster vaccine in people above the age of 50 years. 50 years and above, 2 doses are recommended. And what about the efficacy of this vaccine? So whenever we are discussing about the vaccine, all of you will know that no vaccine is 100% effective, but it is 100% effective in preventing major complications and severe illness. So what about the new recombinant zoster vaccine? Irrespective of the underlying morbidity, the disease, whether it is coronary disease or diabetes or hypertension or chronic kidney disease, more than 90% effective in preventing herpes zoster. And this is independent of the number of medical conditions reported by the patient. And that is quite encouraging. And this is a pooled post-hoc analysis of ZOE 50 and ZOE 70 clinical trials in people 50 years and above and 70 years and above. The vaccine efficacy is 91.2% effective. Quite satisfying or above our expectations. And this is in more than 30,977 participants in multiple clinical trials with this vaccine. And this is the long-term follow-up study, that is 11-year study. So currently, we are not recommending any booster after 2 months. And the reason being, even at the end of 11 years, we can see in ZOE 50 and 70, almost close to 90% efficacy. And we do have the immunogenicity studies in India in people 50 years and above. And these are the 2 classical doses. The primary objective, the vaccine response rate for the anti-GE humoral immune response at 1 month post the second dose vaccine. And it has met the primary objective. The vaccine response was 85.7%. So it has met the primary objective. And now let me come to the considerations for vaccines. Whom will you vaccine? And this is also answering some of the questions very frequently asked by the doctors at the end of our lectures. This is not chickenpox vaccine. Even though you have a chickenpox or even though you had a previous herpes zoster, you need to get vaccinated. If you had a previous history of herpes zoster, you can develop herpes zoster again. And that also is more when compared to those who didn't have a herpes zoster earlier. So having a herpes zoster once doesn't give you an immunity. Of course, one infection of a chickenpox will give you an immunity only against chickenpox. And once you have a herpes zoster, if you go by CDC, you can wait until the symptoms are over and then you can take the vaccine. But if you go by the Canadian guidelines, you have to wait for 1 year. But typically in our practice, we give it after a month or so once the acute symptoms are over after an infection. And the patients who are immunocompromised, if they are on a stable dose of steroids, you can vaccine. You can give the vaccine, or you plan it before a chemotherapy, prior to immunosuppression, or for any other matter, or for any other disease when they are having an immunosuppression. And family history of a herpes zoster, actually studies have shown that it increases the risk of developing herpes zoster. And this is a vaccination schedule, very important slide. Most of you are already familiar. Let me tell you something, and this I am revealing during my lectures. I have taken the vaccine the moment it reached India. And I have taken both the doses of vaccine, and all the family members, 50 years and above, all the friends also, I have recommended, and they have also been vaccinated. It is a trouble-free vaccination. You go by the first dose, and then 2 months later, within the next 6 months, you can have the second dose of the vaccine. So if a flexibility is needed, if the patient cannot come back after 2 months, you can administer the second dose within 6 months after the first dose of the vaccine. And this is 2 doses of 0.5 ml each, administered intramuscularly. Shingrix shouldn't be kept inside the freezer. It can be stored similar to insulin between 2 and 8 degrees Celsius inside the refrigerator. And it is supplied in 2 vials for reconstitution. So 1 vial for antigen should be reconstituted with 1 accompanying vial of the adjuvant suspension. So this sentence is very important. This statement from the approval authorities in India. Shingrix is approved in India. 2 doses of the vaccine for the prevention of herpes zoster and for the prevention of post-herpetic neuralgia in adults 50 years and above. So even if you are not having diabetes or any other complications, if you are 50 years and above, then you are eligible for herpes zoster vaccination. And this vaccine is approved not only for preventing herpes zoster, but also for preventing herpes zoster pain, that is post-herpetic neuralgia, which is a terrible disease. And then if you are having questions on a safety profile, it is similar to any other vaccine. There can be localized pain. I developed a pain which lasted for 2 days, and it will easily subside with the paracetamol. And there can be redness over the arm. And these 2 are fairly common, and others are uncommon. Myalgia can be there for 2 or 3 days, but no severe, because we have given the vaccines to many people, hundreds of patients, and nobody has developed any serious complication. And what about administering this vaccine along with the other vaccines in diabetes? Because routinely we are giving to our patients an yearly influenza vaccine for more than 25 years. We are giving the pneumococcal vaccine. Now we have the 20-valent new conjugate vaccine. So if you go by the recommendations, it can be given along with the other vaccines in people with diabetes. And this is the recommendation from other countries, from Austria, from Canada. This is not a vaccine which is available in India alone. This is a vaccine which is available globally, approved in 61 countries, and millions of doses have been already administered. And no serious side effects. And we have again incorporated in our RSSDI vaccine guidelines along with the other recommended vaccines in people 50 years and above. 2 doses at interval, second dose at 2 months, within 6 months of the first dose. So in conclusion, when we are recommending comprehensive management of diabetes, that not only includes the prevention of heart attacks, heart failure, kidney failure, blindness, and other cardio-renal metabolic complications, it also includes vaccinations such as influenza, pneumonia, and herpes zoster. And here I stop, and thank you, dear doctor friends, for your patience, and thank you for your hearing. And bye-bye from Jothydev in Kerala, in India. Thank you very much.